Good afternoon. In the next 15 minutes, we'll try to see if it's possible to find the right setting when we use the helmet to improve the helmet performance. The helmet was used instead of the mask because sometimes with the mask you have a lot of leaks, so you have to tie the mask to the patient's face, and in this way you increase the risk of skin necrosis, and at the end you don't have air leaks, but you increase discomfort and you fail non-invasive treatment with the mask because of this discomfort. So in 2002 we tried to apply in an helmet pressure support plus PEEP instead just CPAP. We didn't know at that time a lot about the physiology of the helmet, but we saw that during CPAP the esophageal pressure had a swing that it was from 0 to minus 10 centimeters of water. By adding pressure support, 10 centimeters of water of pressure support, we reduced the esophageal swing from 0 to minus 6, so we reduced the inspiratory effort, and probably if we measure the pressure time product of the esophageal pressure, we reduce the work of breathing. And as I told you, we didn't know a lot about the physiologic characteristics of the helmets, but we noticed that the helmet group was ventilated with a significantly higher PEEP, 8 centimeters of water, compared to 5 centimeters of water. This PEEP is nowadays considered the minimum level of PEEP that we have to apply in the helmet to improve helmet performances. And then the helmet patients were ventilated continuously for a longer time compared to the mask patient group. And at the end, no patient in the helmet group developed intolerance phenomena compared to 8 patients that develop intolerance phenomena in the mask group. Other papers, this paper is from Gattinoni group, studied the helmet and compared the helmet to the spontaneous breathing and to the mask. Actually, they compared the mask with an helmet called the large helmet and an helmet called the small helmet. And they saw that compared to the spontaneous breathing, this is the esophageal tracing, this is the tidal volume, and this is the airway pressure tracing. The helmet was able to reduce the inspiratory effort. However, the mask was more efficient. But the authors concluded that simply increasing the level of pressure support during helmet ventilation is possible to obtain same performance that with the face mask. So this was the second take-home message. Probably during helmet you have to use high level of PEEP and you have to use higher level of pressure support that you are used to use during mask non-invasive ventilation. And we try to evaluate the physiologic manner of the helmet in a group of healthy volunteers in which we want to study if the helmet was able to unload respiratory muscles, and if it's during helmet non-invasive ventilation, the CO2 rebreathing is relevant, because when you use helmet with CPAP, you are supposed to use from 40 to 60 liters per minute to avoid CO2 rebreathing. Probably with pressure support, the flow is definitely lower. So in our study on healthy volunteers, we applied different level of pressure support and PEEP, and we did not find any differences in terms of inspiratory pressure of CO2 measured at the mouth, and in expiratory pressure of CO2 measure sampling air from a reservoir bag on the expiratory limb of the circuit. And this finding was related to the volume washing the helmet, that it's different, and by applying higher level of pressure support is increased, while the tidal volume of the patients, of the volunteers, actually remained the same. They were healthy volunteers, so they are not supposed to increase a lot the tidal volume by increasing the level of pressure support. And how about the inspiratory effort? The pressure support with the helmet was able to reduce the pressure time product of the esophageal pressure compared to the spontaneous breathing. How about patients, and how about COPD patients? COPD patients are particular patients with a lot of respiratory mechanics alteration, In this study with Paolo Navalesi, we evaluated the effects of helmet and the mask in stable COPD, and as you can see, this is the airway pressure and this is the transdiaphragmatic pressure. We have a huge inspiratory trigger delay. Part of this delay is due to the intrinsic PEEP, but the most part is due to the characteristics of the helmet. And then we have a short time of assistance, and during helmet ventilation, especially in COPD, this is something that can be frequent because we can have a triggered breath and then we can have 2 wasted efforts. So the work of breathing of the patients is not decreased, and this is our goal of mechanical ventilation. In this study, we showed that the helmet was able, as the mask, to reduce the PaCO2 and to increase the PaO2. But when we went to look to the inspiratory effort and to the work of breathing, the helmet was able to reduce the inspiratory effort and the work of breathing compared to the spontaneous breathing. But again, the mask was more efficient than the helmet. So the problem is that when you use the helmet, you have to see what kind of helmet you are using, and this was a paper published when on the market there were just 3 helmets, 2 European helmets and 1 American helmet, and the intrinsic characteristics of the helmets make some differences between the non-invasive ventilation with the helmet. This is the time of assistance. This is a bench study on a mannequin connected to an active simulator, ventilated with the helmet, with 3 different settings: a default setting, a very slow setting with a very slow pressurization ramp and a very low expiratory trigger, and a fast setting with a very fast pressurization ramp and a very fast expiratory trigger. And as you can see, the 2 European helmets were able to improve the time of assistance by increasing the setting, by using fast settings compared to the American helmet. You see a very short time of assistance, both at 20 and 30 breaths per minute, because with this helmet we have a lot of asynchronous, like autocycling or wasted effort phenomena. And what happened in patients? Frédéric Vargas and Laurent Brochard published this paper in which they compare the face mask to the spontaneous breathing, and the face mask with an helmet with the same setting of the face mask and an helmet with a specific settings. The specific settings was obtained by increasing pressure support, PEEP, and by using the fastest pressurization ramp that was possible on the ventilator. And what are the results? As you can see, the flow, the esophageal pressure, the airway pressure, the transdiaphragmatic pressure, the last tracing. The face mask was able to reduce the inspiratory effort compared to the spontaneous breathing, and the helmet with the same setting of the face mask was less efficient, but when they applied a specific setting for the helmet, they obtained the same results they obtained with the face mask. So they concluded that when you use the helmet, probably you have to use a specific setting. But they did not evaluate the role of the expiratory trigger. That is also important. So we studied in healthy volunteers the influence of different pressurization ramp and expiratory trigger in healthy volunteers ventilated with a face mask and with an helmet with 2 different respiratory rates. And these are our results in terms of inspiratory trigger delay and expiratory trigger delay. And it's clearly shown with the black column we have the mask, and with the light gray column we have the helmet, that the fast settings is able to improve both with the mask and with the helmet too, both the inspiratory trigger delay and the expiratory trigger delay at 15 and 30 breaths per minute. And this can be translated even in a better assistance. But when we went to match the time of assistance, so the time in which the patient and the helmet were in synchrony with the neural time of the patients, we found that, as expected, the mask followed the neural time of the patients. So the time of assistance is longer when the patient breathing is lower, and in increasing the patient breathing, the time of assistance is lower. Look at the helmet. With the helmet, the time of assistance is completely independent from the neural time of the patients. It means that the helmet has proper characteristics with a proper time of response that is independent from patient neural time. We concluded that when you use the helmet, you have to use a specific setting and probably use a fastest pressurization ramp and a fast expiratory trigger may improve both with the increase of pressure support and PEEP helmet performances. But when you ventilate with an helmet, you have even to pay attention to the kind of ventilator that you are using, because not all the ventilators have the same performances. And in this study, we compare 4 ICU ventilators and a ventilator with a specific software for the helmet. And as you can see in our results, at 20 and 30 breaths per minute, this is always a bench study. The 3 out of 5 ventilators have the better performances in terms of delay, inspiratory trigger delay and expiratory trigger delay, both at 20 and 30 breaths per minute. And this can be translated in a better time of assistance of these 3 ventilators, both at 20 and 30 breaths per minute with the default setting and with the fast settings. And always the fast settings significantly improve helmet performances during helmet ventilation. And then now on the market are present new helmets. We tested one helmet, there is a new helmet, with the 2 old helmets, the StarMed helmet and the Rouge helmet, and we tested this new helmet that can be used without weight and with 2 weights to reduce the helmet compliance. And we found out that testing always with the 3 different ventilator settings, the default setting, the slow setting, and the fast settings, at 2 different respiratory rates, 20 and 30. The new helmets improve the inspiratory trigger delay compared to the old helmets and the expiratory trigger delay. And at 30 breaths per minute, these are our results: a significantly lower inspiratory trigger delay and a significantly lower expiratory trigger delay, especially with the fast settings. So it means that probably the new characteristics and the lower compliance and different material of the helmet may strongly affect helmet performances. And this can be translated in a better time of assistance when you are using an helmet with better performances. And we analyzed the performances of these 2 helmets by analyzing the pressure time product in the first 500 milliseconds. That it's a measure of the ventilator and of the interface performances. And we found out that the new helmet, without weights and with weight, there were no differences between the 2 modes of using this helmet, had better performances compared to 2 old helmets in terms of PTP 500, as you can see, at the default settings and especially at the fast settings. So the take-home messages probably can be that when you use the helmet, the old or the new one helmet, you have to set the ventilator in a different way, pay attention to take the fastest pressurization ramp and the fastest expiratory trigger delay that you can, because in this way you definitely may improve patient-ventilator interaction and helmet performances. Thank you.